Dr. Benny and Dr. Gehan. My talk today will focus upon the giant retinal lakes, the challenging situation for vitreoretinal surgeons. What are giant lakes? Skippins in 1962 defined giant lakes as circumferential retinal lakes of 90 degrees or more. These lakes may extend to 180 or even 360 degrees. And the definition of such covers also a large dialysis, which is the disinsertion of the retina and the vitreous vein at the aura serrata, and the pathogenesis of which, and hence the management of dialysis, which is the disinsertion at the aura serrata, is entirely different. Giant retinal lakes represent a special therapeutic challenge, and maybe 20 years ago they were one of the leading causes of blindness among vitreoretinal surgeons because the success rate at that time with the old techniques was limited. This is a picture of the giant lake, a diagram of the giant lake showing how the retina is cut and folded over itself over the posterior fold. What causes giant lakes? Idiopathic giant retinal lakes are commonly bilateral, suggesting an oblique position. It is born in males, and there is a high incidence of myopia among these patients. Surgical trauma as anterior retinectomy and lensectomy, and we have seen children who have been operated before by lensectomy at younger age and develop giant retinal lakes later in life. Lung trauma associated with avulsion of the vitreous phase throughout all or parts of the lake may also cause giant retinal lakes, as well as Scleral vitreoretinal dystrophy, and in such cases the lake is usually at the posterior margin of the vitreous phase. Rarely it is in the ciliary epithelium or the anterior margin of the vitreous phase. Large areas of chorioretinal scarring, as we see in patients with acute retinal necrosis syndrome, may also develop giant retinal lakes, and in such cases the anterior flap of the lake is necrotic due to inflammation, and these patients also develop multiple pinhole-like breaks along all the retina, which is the necrotic retina as a result of inflammation. Nasal giant lakes have been reported in eyes with nasal coloboma of the lens, and rarely it has been reported in eyes with retinitis pigmentosa. Now, what are the features of giant lakes? There are two important overriding features that dictate the behavior of giant retinal lakes and distinguish them from all types of broad retinal lakes. First, because of the size and the fact that the vitreous is attached only to the anterior flap, as we see in this diagram. As we can see in this diagram, the vitreous is attached to the anterior flap of the plate, while it is completely detached from the posterior flap. Therefore, this fact allows mobility of the posterior flap to be independent of the anterior one, allowing the posterior flap to roll over itself freely backwards. So, the first fact in giant lakes that there is a posterior vitreous detachment. Vitreous is attached only to the anterior flap, while the posterior flap is freely mobile and no vitreous is attached to it, as we can see in this diagram. Folding of the posterior flap can occur to such an extent that the gel can come to lie behind it and prevent it from returning back to its original position. So the vitreous would relax behind the giant lake. The vitreous would come to lie behind the flap, the posterior flap of the giant lake, and prevent it from folding back to its original position. As we see in this diagram, the vitreous is tightly adherent to the anterior flap. So this is the end result, that we get a giant retinal lake of more than 180 degrees. The posterior flap is inverted over itself, and vitreous comes to lie over it, preventing it also from coming back to its original position. This is another example of the folded flap of the giant lake. Now, whereas the size alone dictates the behavior of the giant retinal lake compared with the horseshoe tear, in which vitreous attachments are comparable, size alone is not the fundamental characteristic. As we can see, large tears of less than 90 degrees can also behave like giant retinal lakes. This is a larger break, and there is starting a posterior extension of this radial extension of the giant lake And it can be managed as a giant retinal break. So, moving to retinal dialysis, which is the most important differential diagnosis of this case, the fundamental difference between both conditions is that in retinal dialysis, the attached gel to the posterior flap prevents its inversion and keeps it in place. So, in giant retinal plates, the gel was attached only to the anterior flap, while in retinal dialysis, which is this insertion of the retina in the ora serrata, the vitreous is attached to both flaps. This fact has very important consequences. So, because giant plates are associated with PVD and the posterior flap is free, as we mentioned, the RPE cells can easily gain access to the retinal surface and cause a rapidly progressive PVR. While in retinal detachment associated with retinal dialysis, the posterior hyaloid is attached, so there is no PVD, and the access of the pigment epithelial cells and their dispersion is limited compared to giant plates, and PVR is uncommon. Why is this differentiation between both conditions important? Because the unwitting conversion of dialysis to a giant plate by doing a vitrectomy and detaching the hyaloid can spell disaster in such a case of dialysis, because you have converted the dialysis into a giant plate. While you can manage a dialysis quite easily with a scleral bucket, now you have converted it into a giant plate with all its consequences and relatively less favorable prognosis. So a clear definition of what constitutes a giant plate is therefore of crucial importance, because it affects the choice of your surgical method and the likely prognosis and outcome. This is another diagram showing you the giant retinal plate and the folded retina over itself, and the bare retina of the retinal pigment epithelium. And pigment epithelial cells disperse very easily into the vitreous cavity, causing PVR and folding of the retina, as evidenced in this diagram. And this is, on the other hand, the dialysis. And we can see that the flap, the posterior flap, is not inverted, and you can easily treat this case with a scleral bucket. So giant plates have a tendency for rapidly progressive PVR because of the large area of their RPE cells that can migrate into the vitreous, the relatively younger age of these patients, and the need for excessive thermal treatment as laser or cryo in older times that may cause breakdown of blood ocular barrier. What are the eyes of high risk of PVR in such cases? These are cases with extensive dispersion of RPE cells, having extensive tobacco dust in the vitreous, extensive flare, vitreous hemorrhage, because the blood would provide the proliferative factors that promote the proliferation of RPE cells, and cases with hypotenuse syndrome and choroidal detachment due to breakdown of the blood ocular barrier and the influx of proliferative factors that promote proliferation. So although our current success rate with modern techniques in giant retinal plates ranges in the 90 to 95% after surgery, the reoperation rate in such cases is higher than other types of retinal detachment and ranges from 12 to 15%. So what would be the management of giant retinal plates? Before we proceed with the management, let's see how it evolved, our management for giant retinal plates over the years. Before vitrectomy, giant retinal plates were considered to be a blinding condition. And Skippens stated that such giant plates are among the most discouraging conditions in vitreoretinal surgery, and he also called for the importance of finding better methods of management for this condition at his time in the 60s, and it is made more imperative by the fact that it may be bilateral and the number of patients may be affected at a younger age. So, before the advent of fluorocarbon and modern surgical techniques, a wide variety of surgical techniques have been described, and none of them had actually a favorable outcome. Techniques were based on creating at that time a broad scleral buckle and rotating the patient to unfold the flap and to perform a fluid air exchange in the prone position, as we can see, which is now, I mean, it's like a joke in the operative theater to have such a scene. So what's the current management of giant retinal plates? Giant retinal plates are currently managed by pars plana vitrectomy, removing the core vitreous curve, unfolding the flap using perfluorocarbon liquids, doing an anterior retinectomy and removing the anterior flap to which the vitreous is firmly attached, doing endolaser, and finally changing silicone oil. There are key steps in the management which we are going to see in the video right now, which are unfolding the posterior flap is the first step towards successful treatment, and to accomplish this you have to remove the core vitreous and any vitreous behind the flap, preventing it from repositioning in place. We flatten the posterior flap against the eye wall and create a firm chorioretinal reaction. Anterior retinectomy is also an important step to remove the anterior flap with the attached vitreous, otherwise its future contraction may contribute to recurrence of the case. Endolaser is done to the edges of the blade, filling the globe with PFC completely, and finally doing a direct PFC silicone oil exchange without doing a fluid air exchange, as we will explain later. Because there is a posterior vitreous detachment in giant retinal veins, initial vitrectomy, removing the core vitreous, is relatively easy. It's not a problem because you don't have to do a TVD in such cases. But special attention should be given to a highly mobile flap that may get caught into your vitreous cutter. Removing the vitreous behind the flap is important. That prevents unfolding of the flap. I'm going to show you the video now. Now, so this is starting the case. I'm doing a core vitrectomy. As we can see, there is a case of a giant break, almost 180 degrees, and the flap is mobile, and vitreous is collapsed behind the break. So I'm doing my initial core vitrectomy, clearing the central vitreous and removing vitreous from behind the flap. This is continued until I remove also the vitreous in other parts of the retina. You don't have to remove it in the periphery until you can find that the retina is mobile enough that you can start your injection of perfluorocarbon. This is the injection. Sorry, this is going too fast. I didn't get it back. معلش هنرجع تاني شوية. So رجعنا ورا شوية كده وابتدينا احنا كنا حققنا ستيب شوية من البرفلوروكاربون. أنا جديد في الأكل فعشان كده بستعين بالدكتور حسن. احنا بنشيل الفيتريس زي ما احنا شايفين دلوقتي، وحققنا perfluorocarbon شويه على البوستيريور بول، and it is important when you inject شويه perfluorocarbon دول انك تمنتين some vertical direction للفلاب. you don't deposit it على الباك سيرفيس عشان تقدر تعمل لها proper trimming زي ما هنشوف بعد شويه. دلوقتي انا بعمل endodiathermy to the edges of the giant plate لان الedges can fall. So I have to do endodiathermy before trimming it with the vitreous cutter using low vacuum settings علشان ما اشيلش كتير من البوستيريور flap of the retina. Okay. بعد كده بنبتدي بقى نعمل trimming للبوستيريور edge زي ما احنا شفنا. We have to be very cautious, otherwise ممكن تلاقي نفسك انت بتعمل radial cuts في الريتنا بالكتر بتاعك. One of the very important steps كمان ان احنا we have to clean the horns of the giant plate. because الهورنز دي هي الاريا اللي فيها الثيرد attachment of the vitreous زي ما احنا شايفين، ودي السايت of future extension of the giant vein. More perfluorocarbon is then added، وزي ما شفنا الفلويد بقى displaced في البريفري في اريا ثانيه. نكمل injection of perfluorocarbon بتاعنا. And then we start doing endolaser to the edges of the giant vein, and preferably to continue it كمان with 360 degrees علشان to secure the retina. Sometimes I add a single cryo application at the hole علشان ابقى متاكد ان ما حصلش، مش هيحصل في الحته دي future extension، وان انا وصلت as anterior as possible للريتنا. يمكن لو ما قدرتش اوصل لها بالإندنتيشن او كده يبقى بعمل a single cryo application at the holes. Otherwise I don't use the cryo in such case. بعد كده احنا بنكمل نعمل a complete perfluorocarbon fill of the eye. والفاينل ستيب اللي احنا هنعملها هي ان احنا هنعمل direct perfluorocarbon silicone oil exchange. في some tips عايزين نتكلم فيها هنا. اول حاجه PFC injection. You have to do a slow injection of PFC over the optic disc. And what I do علشان ما يحصلش expulsive injection of PFC in such cases ان انا بقاد 1 cc of air over the PFC. وبالتالي لما كومبريس السيرنج بتاعتي فالاير يبقى كومبريس جراديولي وبعدين يزق البي اف سي، ما يحصلش sudden explosion of PFC من الفلوت نيدل بتاعتي، بحيث ان انا في الاخر الاقي عملت ريتينال هول من الفورسبل انجكشن اوف PFC. Why inject 40 to 50% PFC until the edges of the blade stand vertical in the mid-vitreous cavity. We have to work on the edges of the blade زي ما قلنا with special attention to the horns on each side, because vitreous is firmly adherent to the horns. This is the possible site of future extension and recurrence, and we trim the horns, paying special attention to trimming the vitreous up to the retinal surface in this area. Anterior retinectomy, removing the anterior flap, is mandatory using scleral infiltration, and if left, the anterior flap will roll over, fibrose, and exert traction, causing recurrent retinal detachment or traction of the ciliary body and hypotenuse. Now, a critical step that we have to do is the complete perfluorocarbon liquid fill. And this is very important because when silicone oil enters the eye, there must not be a single drop of PSS inside the eye, as if there is any residual fluid at the time of PFC silicone exchange, fluid will pass through the edges of the giant vein, causing slippage and backsliding of the edge with recurrent retinal detachment and retinal pores. And in order to understand this, we have to go back a little bit to physics. It seems logic that we have inside the eye 3 liquids, which are perfluorocarbon, water, and silicone oil. This would be their logic arrangement. Perfluorocarbon is the heaviest, followed by water, and silicone oil is light and floats on the surface of water. So we would have actually 3 bubbles inside the eye. If this was the fact, slippage would not have occurred. What happens actually inside the eye? Now, as we all know by definition, water is hydrophilic, while silicone oil and perfluorocarbon liquid, both of them are hydrophobic. This physical fact renders the arrangement of fluid inside the eye totally different than we expected. The hydrophobic liquids unite together in one big bubble formed of perfluorocarbon below and silicone oil above it like this, while water gets displaced to the side. And why this happens? Because when 2 hydrophobic liquids are together in a solution, it is less energy expenditure for all molecules to unite in one bubble like this, despite the difference in weight, perfluorocarbon being much heavier than silicone oil. Therefore, in an eye which has water, silicone oil, and perfluorocarbon, where is water located? It is located to the side of the eye, exactly over the giant break, where the giant break is. And when you inject silicone oil more, water is pushed to the side behind the retina, causing the posterior slippage. What I usually do in order to avoid this problem, I inject perfluorocarbon until I fill the eye, then I disconnect the infusion cannula completely. and continue injecting perfluorocarbon until it starts dripping outside in a water container. Perfluorocarbon starts to drip inside. In this way, I am sure that the eye has been filled completely with perfluorocarbon, including the tubing. Then I start connecting my silicone oil syringe and inject. So this explains to us why posterior slippage happens in such a case. So since both silicone oil and PFC are hydrophobic, both fluids tend to form one continuous bubble, and this consumes less energy for both fluids than two separate bubbles. As more silicone oil is added and the pressure increases, water is pushed to the periphery under the posterior edge, causing slippage. So, what is now the role of scleral buckling? In my opinion, scleral buckling has no role in management of giant retinal lakes with no PVR or even with some PVR. Because I believe that if you vitrectomize the eye, the dynamics and the fluid dynamics of the eye cannot match with the scleral buckle. Scleral buckle will have no role. But we have to also show you some other opinions of other surgeons which believe that in cases of PVR, they may put a scleral band which is low to support areas of the retina which are not on the side of the giant retinal plate. But I believe, and many other surgeons believe, that there is no role for scleral buckling in such cases. What would we do for the lens? Fresh giant plates with no PVR, the lens can be preserved. If you have an anterior PVR component, removal of the lens may facilitate the section of such anterior component, and IOLs are generally left in place unless they are unstable. What would we do with fellow eyes of giant plaques? Retinal plaques develop in fellow eyes of 51% of patients with giant plaques, and giant plaques develop in fellow eyes of 16% of such patients. So we have to examine the very eye very properly, the other eye very properly and thoroughly, and if you have an increasing white without pressure, which is present in 90% of fellow eyes with giant plaques, then we can consider prophylactic treatment in such cases, even prophylactic buckling or laser or cryo, whatever is convenient to the surgeon. Now I would like to remind you all of our EGPRS International Meeting, the Egyptian Vitreoretinal Society International Meeting, which is going to be from the 9th to the 11th of January 2015. هيبقى فندق فيرمونت هليوبلس زي ما عملنا المرة اللي فاتت, and we have a distinguished Egyptian and international faculty for this meeting. Besides, we also have instruction courses that will be available on the 9th, while on the 10th and 11th we will have the main sessions of the meeting. Thank you very much again, and at the end أنا كنت عرفت من الدكتور ماجد إن في أسئلة بالنسبة للتريننج سكول عند ناس كتيرة, فلو في حد عنده أي سؤال بالنسبة للموضوع ده أحب أجاوب عليه.